Good afternoon. Terrific to have you with us today, particularly since I have such a very special guest with me for the lunchtime show. That's Dr. David Nabarro, one of the 6 special envoys for the World Health Organization for COVID-19. David, I'm truly flattered and very impressed that you're able to spend 30 minutes with us today. Thank you for joining us.
Thank you, Stephen. We ourselves were together on a really intriguing and novel operation in response to a crisis 20 years ago, and it's an absolute joy to be back with you and joining you today for this important briefing moment.
I think it was 30 years ago now, David.
Okay, it makes me feel younger.
I haven't given you a big build-up this lunchtime because I've done that over the course of many emails over the last week, but if I can pick out a few highlights. Going back to the early 90s, you were appointed a CBE for your work on international health. You've been a senior representative for the United Nations and the World Health Organization on cholera and Ebola and malaria. And I can hardly overlook the fact that a couple of years ago, you were kind of pipped at the post in the competition to be the actual Director General of the World Health Organization. So I don't think we can doubt your credibility, your qualifications, or your experience in the field of healthcare. Can you tell us what's going on in the WHO at the moment with regard to COVID-19?
Well, the organization has just been working flat out on this particular challenge since early January. It was recognized just how serious the new virus is towards the end of January when human-to-human transmission was confirmed and the figures came through that this is a highly transmissible coronavirus with a relatively low fatality rate. Those of you who know about diseases, particularly infectious diseases, will realize that it's the low fatality rate that makes this particularly dangerous, because it means that there's very little preventing the virus from going on spreading. And as it has this R0, which means the number of people who are infected by one person who has the disease, of the order of 2.6 or 2.7, when it's moving through a community, that means it really is extremely infectious. And outbreaks build up very, very fast through person-to-person transmission. And because of the low fatality rate, it makes it very hard for this virus to be expected to die out, as we had with some of the other major viruses that we've been worried about. And so the organization's just been totally focused on 3 things. One is learning about the virus and trying to understand what it does to people, but also whether or not there is immunity developed after infection, and also what patterns of treatment are the most effective. The second thing WHO has been doing is trying to get everybody to understand that it's a really serious virus and that you have to act rapidly and robustly to contain it and to stop it from spreading. And the earlier you act, the easier the challenge is. The later you act, the bigger the problems. The third thing the WHO has been doing is trying to encourage unity of response, particularly within countries, because consistency from the top to local level is so important, but also throughout the world, because this is a global threat. And we can't actually succeed if countries are working at counter positions to each other. Those are the 3 things, and the organization's just been doing that, as I say, without stop, without any stop at all since it started.
How do you feel you're getting on with that? Because, you know, if you look around the world, you've got countries like Brazil, where it would seem that they have a completely unique attitude towards this disease. We've got the Americans who've just pulled $400 million worth of funding for the WHO. And I always wonder, when I've worked with international organizations, hardly to the extent you have, but I always wonder about their effectiveness because of the amount of infighting and conflict between the players.
Well, I like always to stress to people that there are 2 layers in the World Health Organization. Layer 1 is the heart of the organization, 7,000 professionals in 100 offices around the world, 6 regional bureaux, and then the Geneva headquarters, all dedicated to public health and to collective well-being. I've loved my association with the WHO. There's an extraordinary spirit of total dedication to the health of all with no discrimination with regard to what country you come from, your ethnicity, your sex, or any other attribute. They work well, and they're very well networked within countries, across universities and the like. Then there's the second level, which is the owners of the WHO, 194 countries. We call them member states, and they tend to argue quite a lot, argue about priorities, argue about whether or not the organization's spending its money well, and then occasionally argue about quite major political challenges between them. And just at the moment, the member states are pretty much in agreement. That's 193 of them. They just met in the middle of April and really gave the WHO Secretariat a huge vote of confidence. But one particular government did decide to express frustration and has subsequently withdrawn, which is such a pity, because the United States has been a tremendous advocate for global health security over the years. I've worked with so many American professionals, and my wish is that we could somehow be spared this particular blow coming right at a time when everybody is so massively focused on this pandemic, which I'm afraid is still at its early stages. It's nowhere near even the halfway mark right now. And that's why we've all got to be focused on it.
If I can get to specifics for a moment, given the nature of our audience here today. I mean, yeah. The WHO seems to have sat on the fence about the issue of face masks. Can you explain that?
So the position of the organization about how best to stop COVID outbreaks from building up in communities, to stop the big outbreaks that we've seen in the UK and in the US, the best way to do this is through a comprehensive strategy. Firstly, doing everything possible to prevent the virus from being transmitted from person to person. Secondly, if transmission starts, interrupting it straight away through identifying cases and isolating them, identifying the contacts and isolating them. And thirdly, when an outbreak does start, containing it very fast by restricting movement and finding those with disease and isolating them. It's fairly basic, actually. And it's exactly what we've done for other communicable diseases over the years. Now, preventing transmission when you've got a virus that is droplet-borne, conveyed mostly in respiratory secretions, involves obviously hygiene, hand hygiene and surface hygiene. Then it involves physical distancing. And we say 2 meters is the preferred distance for people to maintain to get the lowest possible chance of virus being transmitted from person to person. And then thirdly, some form of face protection. I mean, the most obvious one, if you're trying to prevent spread, is when you cough, to cough into an elbow, or to put your cough into a tissue and dispose of the tissue, washing your hands carefully. But there is the alternative, which is to wear a face protector. Now, the reason why face protection has become controversial is that there is a certain kind of face protector, the really good particle filtration masks, N95 or FFP, that you want to preserve, if at all possible, for those whose occupations mean that they're going to encounter a lot of people with the virus as they go about their work, particularly people who are working in healthcare settings. We need to preserve the best masks for them. And there's a world shortage. And the big worry was at the beginning that if we started suggesting that everybody should be masking as part of the effort to prevent transmission, that there'd be even more stockpiling of the precious masks that would therefore not go to health workers, particularly in poor countries. So WHO was very clear. Face masks of the best kind, please keep them for the workers who are most exposed. So then there was a question, well, what about other forms of face protection? And because there's quite a lot of debate about the effectiveness of some kind of scarf or other homemade protection over your mouth and nose in preventing droplets from being transmitted and preventing people from being infected, the WHO maintained a slightly equivocal stance, saying the science is not clear. And I think that's right. I think that when issues aren't clear, there should be some willingness to say that. However, as it's become clearer and clearer that physical distancing just cannot be maintained in many occupational settings. For example, in particular kinds of factories where people have to work close together, or in public transport where bus drivers are exposed, or security guards when they're at the door of shops trying to stop people from misbehaving. So some form of face protection is clearly desirable for two purposes. One is in case you have relatively asymptomatic COVID, because if you've got symptoms, you should be at home. But if you've got asymptomatic COVID, you're not sure, and you have to go out, then you absolutely should be wearing face protection to try to prevent others from being infected. And then more generally, in public places where people have to be close together, like in, for example, overcrowded public transport, then the organisation is saying, if the national authorities wish you to protect yourselves with face protection, then the WHO says good. But please don't be deceived that if you're wearing face protection, you somehow don't need to worry about physical distancing. You still have to take that seriously. Please, if you're wearing face protection, don't spend your time touching your mouth and adjusting your mask or fiddling around with it, because then that just actually creates a very unsatisfactory situation and may lead to spread. And thirdly, please, if your mask gets wet or your face protector gets wet, try to take it off, put it in the wash it and put on a dry one, because wet face protectors are not very useful because they prevent air from flowing to and fro. This will continue to be controversial, but my own personal view as somebody who's in his 70s and who does not want to get this disease is that when I'm out and about, particularly in more crowded locations, you'll see me wearing a mask.
The most recent research I saw, actually, there was something in a news article a couple of days ago about hamsters having been tested. I think hamsters are one of the few animals that are also susceptible to COVID-19. And it showed that obviously the hamsters weren't wearing masks, but the equivalent of the uninfected hamsters wearing a mask reduced their infection and fatality by a third. The effect of putting masks on the infected hamsters, it reduced the contamination by a sixth. So there is some evidence there that it works. I would guess. A couple of questions for you from two of our viewers at the moment, asking about antibody testing and whether you think that we're likely to get it soon, and will it be of any value?
So there are two kinds of tests, Stephen, that we tend to use. The first and the most useful test is to see whether you actually got the virus in your respiratory system. And it's the famous one, so-called PCR, polymerase chain reaction. It's difficult to set up and to execute, and to take the sample, you have to push a swab deep into somebody's nose or deep into their throat to try to get the secretions where the virus is most likely to be. It's a difficult test. It's one that's not available in most locations in our world at the moment, and one that, frankly, it takes an awful lot of time to execute. And so there's an alternative approach, which is to test people to see whether they've either had the virus for some days or have had an infection with the virus in the past. And that's picking up antibodies to the new virus. And there are more and more of those coming on the market. Your questioner is right to ask, are they reliable? Because on the whole, many of the tests that have been available, even some that can be purchased through the internet, seem not to be as reliable as they should be. They give you false positives, suggesting that you might have been infected when it was due to another coronavirus. But they will be for working out who's been infected, for knowing where the disease has been and is moving, and also for individuals who want to know whether they've had the virus. Just one small note, we still do not know for sure that if you had the COVID once, you've got long-term immunity against getting it again. So we must not overinterpret the results of antibody tests. That does not necessarily mean, even if you've got a positive antibody test, that you are immune to getting the disease again.
I struggle myself with something which is probably quite simplistic, but that is to say, let's assume for a moment, and I know it's a big assumption, that you are immune from further infection if you had COVID-19. Surely you can still pass on the coronavirus to other people, because you could have it in your respiratory system, even though it's not causing COVID-19. You could breathe on other people. So you could still be a source of contamination, even if you're not actively infected.
That's absolutely right. You see, we have a whole series of issues about this question of immunity. Is the immunity strong enough to prevent the virus from colonizing your respiratory tract at all? or is the immunity partial? And does the virus arrive there, but just not go ahead and cause disease?
Yeah.
These are the kind of questions that are also being looked at by the vaccine developers. And they're having to do very careful studies to see whether or not the vaccines really do stop that virus from landing at all. Because that, of course, as the point you make, is so important, because the thing we most want to do is to prevent people from getting ill and at the same time prevent them from being vectors of the virus to others.
There's another thing I wanted to ask you as well. We live in a world where people can spread all sorts of misinformation that the 5G masks have caused coronavirus or COVID-19, that taking hydrochloroquine is going to cure it, from some rather famous and loquacious sources. You at the World Health Organization have started a campaign for something called Verified, I think it is. How does that work? How do we improve our communications through that method?
Well, I think that everybody who's involved with this virus, and that's everybody in the world, is really looking hard to find ways to make sense of what's going on. For many people, the notion that a virus can bring at least half the world to a standstill within a matter of months is beyond any kind of science fiction, beyond any of the movies that we've ever seen about infectious disease. And that need to make sense of it includes sometimes finding people to blame. And in the finding of blame, various conspiracy theories have emerged. Some of them are really horrible. Some of them are vaguely plausible. Some of them are just right off on left field. What we wanted to do right through the World Health Organization was to offer verified information, a bit like you get verification in a Twitter account, just to try to show people what seems to be shown as decent evidence and what's still conjecture and what is absolutely not proven at all, like the 5G masks spreading the virus, which seems to be quite popular with some people, and being clear on that. Now, the hydroxychloroquine issue is important. This is a medicine that's been known for years to have some antiviral properties. So it's not unreasonable that people should be looking at it as a possible way of reducing the severity of COVID infections, or even for preventing them. And nobody inside my organization says that it's wrong that people should be thinking this through. We just simply say that there are protocols available for assessing whether or not a medication is effective. They're not easy to do just in the middle of an emergency like this. You have to use observational studies, and they are, frankly, always contentious. But what's happened is that the observational studies that have been done on hydroxychloroquine do suggest that it's not quite the solution that everybody hoped. And so WHO has said, let's stop the studies of hydroxychloroquine, particularly those where there's any suggestion that people are given hydroxychloroquine as a potential therapy, until we've checked the data. And that's happening right now. And I think that that's why having an outfit called the World Health Organization is so useful, because when you've got lots of different pieces of information, you need people to sift it and to sort it and to then come out with some kind of judgment and to be accountable for it, which of course everybody is in that organization. And so I suppose that really is one of our best offers to the world right now.
If I can take you back down to the sort of clinical level again, somebody sent in a question saying that if we're treating in clinic and we're wearing the recommended PPE as laid down by our own representative bodies and government, and one of our patients subsequently turns out to be COVID-19 positive, should we then have to self-isolate ourselves despite all those measures that we've taken?
Thanks very much, Stephen. As I listen to professionals in various different roles talking about some of the challenges they face, and I'm here talking about school teachers, residential care workers, supervisors in factories with busy shop floors and so on, the way in which I'm trying to share with them my understanding of what's happening is in terms of risk. That we do need, as a society, to be able to start thinking through what is a risky situation, and then at the same time to be able to calculate how much risk we are prepared to tolerate for ourselves and also for our co-workers and our families. You can't do it with just hard and fast rules. For example, we know that although you usually don't get infected by somebody with COVID if you are more than 6 meters away from them, but at the same time, there are stories of extraordinary spread of the COVID in choir practices where people are really getting a lot of air into their lungs and belting out a loud note. And this stuff seems to aerosolize and fly much further. Then we hear stories about people who are meeting up close together out in the open, compared with people who are close together in confined areas. And it seems that the virus spreads much more easily in confined areas than in ventilated areas or in the outside world. And then we hear of people saying, well, we were in contact with an infected person really just for a very short period of time and they didn't cough and we seem not to get the disease. Whereas others saying, I was in contact with a coughing person for about 15 minutes at the dinner table and I got ill and I then went and infected others. So in summary, I would say, number one, please try to work out for yourself what level of threat you're prepared to accept for yourself and others, whilst at the same time recognizing that as a practitioner, you have an special responsibility because the last thing you want to become is the focus for infection. Number two, if your premises are well ventilated, this makes a huge difference to whether or not transmission is likely to occur. Three, if you are protected properly with well-fitting, particularly face protection, and you're practicing good hygiene, that makes a huge difference. Number four, if the contact was cursory, brief, not associated with coughing, that may be much less significant than if the contact was lengthy, you were very close to the patient's face, and the patient was coughing and had other symptoms, and you asked them at the end, well, what's going on? And the person says, well, I just woke up this morning with fever and cough, and I don't know what's going on. You should probably be a little bit frustrated because that person should not have come to receive treatment from you. And so I would suggest that, number one, please be really careful to make certain that your patients are in good health before you agree to see them. And if there's any symptomatology, make sure they stay away. Number two, please be really careful to limit the amount of contact you have that's close enough to their mouth to possibly get the droplets. And number three, if the contact has been cursory, then probably you can make a decision not to self-isolate, but you do need to be really careful. And if you yourself feel worried about yourself, about your family, about your patients, about your co-workers, then you better self-isolate and ideally get a test if you've got symptoms at all.
And interestingly, we always bang on about the need for accurate and comprehensive case histories in our practices, quite apart from this. But actually, if someone calls me a week after I've treated them and says, I think I've got COVID-19, I would need to be able to check from my notes exactly what I did in the clinic that day before I can perhaps make that risk assessment that you've talked about. So important there. Gideon has asked about why it is, if COVID-19 has such a low fatality rate, and of course, I guess it's very hard to judge that given the paucity of data at the moment. Yeah. But if it has a low fatality rate, then why are we so keen to stop the spread of the virus?
Thank you very much. If a disease has a fatality rate of 1%, then of course 1 in 100 people getting the disease will die. If you have a country with a population of 70 million, then of course, if you've got a 1% fatality rate, 700,000 at least are going to die. You will get massive overcrowding of your health services if you don't try to contain it. And you will also, I believe, have a very high level of anxiety among the wider population. This notion that somehow the people who are most at risk, people in older age groups or people with diabetes or hypertension, can somehow be acceptable as a sort of collateral damage from letting the virus move through the population, which was thought by some to be an approach. It was called herd immunity, has proved really to be unacceptable to the majority of decision makers everywhere. And so right throughout the world, in most settings, people are saying, yes, we should contain the virus and prevent it from spreading. But they're also saying, we've got to do this in a way that does not totally paralyze our economies and put a lot of people into poverty. In the World Health Organization, there has never been a recommendation for lockdown as a strategy to deal with the virus. Instead, what we've said is every community everywhere needs to develop the wherewithal to be able to protect against infection, defend against the virus, respond to outbreaks, and protect the vulnerable. But we say if that is done, then life can go on. And so what I'd like to say to everybody is that we're anticipating a world emerging, it'll be a new kind of reality, where we are able to manage the threat of this virus, to get on with our lives, to do our professional practice, and to prevent large numbers of older people passing away and large numbers of health workers and hospitals being overwhelmed. That's the approach that we recommend. And we do encourage every country that imposes a lockdown, while they've got the lockdown in place, to do everything possible to build up these societal defenses so we can all get about our lives while living with the threat.
Thank you. Rebecca's asked a really pertinent question related to what you've just said, and is the World Health Organization involved in weighing up the balance of risk between treating only COVID-19 and therefore risking the deaths of lots of other people who no longer have access to healthcare?
Very, very good point, Rebecca. I have been listening to Tedros, the Director General of the World Health Organization, and Mike Ryan, the extraordinary head of the WHO Health Emergencies Program, with whom I've worked for some decades, talking about what we expect of health services now. And we are very clear, all of us, that dealing with the threat of the COVID is important, but at the same time, maintaining care for people with chronic ailments, people who are having children, women who are having children and the children themselves, people who have accidents, people who have mental ill health and need support. In fact, the whole gamut of healthcare has to be kept going. We've seen countries that have been able to do this by designating either certain hospitals or certain wings of hospitals as COVID ready and certain other parts of the hospital as COVID alert, but fundamentally focused on responding to people's other conditions. The last thing that any of us want is to encourage the paralysis of health services because of dealing with COVID. It's something we are continuing to go on about. And again, it relates to our view of why we don't encourage lockdowns, instead why we encourage a very well and carefully planned approach to ensuring that healthcare services can, as far as possible, be maintained even during this particular outbreak.
Thanks. We were almost out of time, David. So final question, if I may. How's the UK doing in terms of easing its containment measures? I mean, I know you said you don't want to suggest that everyone should go into lockdown as a remedy, but how are we doing? Are we getting it right? Are we getting it wrong? Are we putting people at risk?
Well, many countries that were quite reticent to introduce robust action at the very beginning when they first had cases to interrupt transmission and contain outbreaks fast, had to cope with the fact that because there was a delay in some cases of 4 or 5 weeks since the first cases arrived, the virus has got really quite widely spread throughout different parts of the population. Of course, it's very spatial, but it's still widespread. And that's the case in the UK, that's the case in the US, it's the case in some other European nations. And so the reality is that the lockdown in being imposed did slow the rate of spread. and lead to some kind of peak in the numbers of new infections, even a flattening and reduction in the outbreak curve. But the virus is still there. And as everybody, I think, has now realized, moving around again is going to lead to new outbreaks coming. So what we have been asking all nations to do is to learn from those that have been successful and make absolutely certain that the defense mechanisms are in place in all societies. And that means having the capacity to test for the virus, having the capacity to identify cases and isolate them, and being able to trace contacts and isolate them, whilst at the same time protecting the most vulnerable, and all the time having the public fully aware that they have a role in preventing spread through the way in which individuals behave and societies behave. It's that widespread understanding of the basics, what I call the vital steps, that all countries need to do. And I suppose at the heart of this is consistent messaging for everybody. I think it's coming in the UK, it's coming in the United States, it's coming in other countries. But of course, there's quite a lot of noise about anxieties around the various parts of the economy, businesses going under, people worried about their jobs, which is all understandable. So I think my only request, and one that I think I'm not alone in saying it, of all governments, is please do what you can to make sure that the message from the top is as consistent as possible, and that there's plenty of scope at local level for local authorities, local health workers, local practitioners like yourselves to interpret that messaging and relate to what's actually happening with the virus in their local areas. Because there will be spikes coming up of new cases, new clusters, new outbreaks for the foreseeable future. The real mark of a COVID-ready society is going to be the capacity to be able to contain outbreaks quickly so we can get on with our lives and really live well in this new COVID reality.
David, thank you. I feel immensely privileged that you've given up half an hour of your time to talk to us down at our level of healthcare, considering the sort of people you normally deal with. And I'm told we've been inundated by people saying thank you for coming on the show and talking to us. And
one comment, because Stephen, you know, the reason why I wanted to be in the World Health Organization, as you referred to, Stephen, at the beginning, is because I actually believe the center of healthcare is the individual, and that all of us, whatever our role in providing a service, have a responsibility to empower people to achieve the level of health that they wish to and that they can do. And so I see working with all of you as something that's a privilege for me. When I got the request, I didn't think twice. I said, I want to be part of it. And if I get a chance to connect with you all again, I'd like to. Steve, if there are people who say that I was inconsistent or unhelpful in my reactions, I hope they'll write to you, and I hope you'll send me an email just saying, how do you relate to this one or that one? I honestly, it is a privilege to be of service. Thank you again.